All right, this meeting's coming to order. Good morning, welcome. This is our second June SEB board meeting of the season. Our meetings this year are going to continue to be hybrid. HCA staff will be on site. Board members and other attendees have the option of attending on site or via Zoom. For our members that are public attending via Zoom, our opening slide has information about how attendees can turn on closed captioning subtitles. Also, public meeting attendees will be able to activate their audio and video during designated times, and our staff here at the agency will make that happen. We're going to do roll call, starting with Carrie.
Good morning.
Good morning. Donna.
Good morning.
Good morning. Pamela.
Good morning.
Good morning. Terry. Terry House, are you with us? I see.
Good morning. I'm here. I'm sorry.
Good morning. It's okay. Lara.
Good morning.
Good morning. Omid.
Good morning.
Good morning. Myra.
Good morning.
And Allison.
Hello.
You feeling better?
I am feeling better, but I am not cured, so I'm still a little bitter.
Okay, so not feeling better and bitter. Katie Hatfield.
Good morning, everybody.
Thank you for that update, Allison. Always leading with honesty. And I am Lou McDermott, the agency's Chief Operating Officer and Chair of the SEB Board. With board members attending both in person and virtually, it'd be helpful for board members to hold their questions after the presentations or when the presenter is asking for questions. And if you're attending virtually, we're looking for your Zoom hand. We have no resolution scheduled for action today. The public will be able to provide general comments at the end of the meeting during the public comment period. And at that time, we're going to gather the public participants. We will figure out how much time we have. We will turn on your audio video. We'll call your name, turn on your audio video, and you'll be able to make your comments. As a reminder, if the public has questions during the staff presentations, the presenter's contact information is included at the end of the presentation. The public is welcome to email presenters during the meeting to capture your question for response. Dave's going to give us an overview of today's agenda.
Good morning, Chair McDermott, members of the board. This will be a relatively short meeting. We had considered whether we needed to host this meeting or not, but the tipping point was we wanted to, or actually need to introduce the hearing instrument resolution to keep with our tradition of introducing at one meeting, asking you to act at a different meeting as much as possible. We tried not to vary from that too much. And then we also thought and have been planning a presentation about Senate Bill 5083 and its implications for the programs, and thought that that would be a good other hearty topic to work on during this particular meeting. So after that, we'll have a brief update about benefits 24/7 in our systems, and then public comment, and we'll be off to the races. So no executive session today. As a reminder, bathroom, go down the hall, look to your left if you see the elevators. If we have an emergency, we walk purposefully across the street into the visitor parking lot.
Any questions for Dave? All right, first up is the approval of the June 5th, 2025 meeting minutes. You're behind tab number 3. Are there any comments from the board? Do I have a motion to approve the minutes as written?
Pam Cruz, I move to approve the minutes as written.
Is there a second?
This is Donna. I second it.
All in favor, say aye.
Aye.
Any opposed?
Aye.
Hearing none, June 5th, 2025 minutes are approved as written. Next up, Ryan Ramsdell, UMP team manager in the ERB division, is going to provide some information on the proposed plan year 2026 benefits changes for the Uniform Medical Plan. Materials behind tab number 4. Ryan, welcome.
Thank you, members of the board, Chair McDermott. I am Ryan Ramsdell, UMP TPA Team Account Manager, here to talk to you about 2 items under the UMP benefit design. First, we're going to briefly cover the IRS high deductible health plan update, and then after that, we will move into the UMP hearing instruments information. So as relates to the IRS high deductible health plan HDHP update, next slide, please. We do this each year, depending on what the federal government recommends or advises. And so once again, we do have an IRS approach to setting the inflation and adjustment amounts for the health savings accounts for 2026 up to $1,700 from $1,650. This is more advisory, as it were, to remind you there was a resolution in 2023-06 that made a recommendation that here on and out, the annual deductible level established by the IRS to qualify for the plan as a high deductible health plan would just continue to follow the expectations. There is no action required. Fairly simple. Any questions on that? I believe the resolution's in the appendix.
Yeah, so just as a reminder, the board, year over year, the IRS usually raises the minimum requirement for the tax preferred aspects of this very plan. So the board authorized the agency to just chase the floor of the deductible, and said we would always bring back to you the update. And so this is just that update.
All right, next slide. UMP hearing instruments. Next slide, please. So as background, there was substitute Senate Bill SSB 5262 that was passed in 2025. And this makes an amendment that requires that health plans issued or renewed on or after January 1st, 2026 shall provide coverage for medically necessary hearing instruments every 36 months without any lifetime or annual limit on the dollar amount of coverage, whether provided in network or out of network. Next slide. So what does this mean? It removes the current dollar bill benefit limit for hearing aids. Plans will cover as a standard benefit without a cost share. Coverage will continue to be every 36 months per year. Note that member benefit accumulators will not reset on January 1st, 2026. That just accumulators refers to the fact that if you acquired a hearing aid within that window, it doesn't reset. You aren't entitled to another 36-month window. You're sort of burning that down. Expect similar member experience with in-network providers, and then we will be doing quite a bit of open enrollment communications and include information about these changes. I should note that this bill applies to the fully insured carriers as well, and they are addressing those expectations of this bill, and adjustments will be rolled into the rates later in this season that you will see. A side note on this as well that I should probably call out is that if a member chooses to purchase a specialty hearing aid and the cost exceeds the allowable amount, the provider may ask that member to sign a waiver to allow them to pay out of pocket for that. There's no requirement for that, but I do want to mention that if an individual wants more than the allowable amount related to covering a hearing aid, that would be at a member cost.
And Ryan, I also want to add for the board that the changes from the legislation they removed the dollar limit. The structure of this benefit in the portfolio and in UMP has been without cost share. It's always possible later if the board wants to consider a cost share on hearing instruments that you could do that. There's nothing prohibiting that in the law. In fact, I think that's actually permissible under the statute, but the structure of the hearing aid benefit, some of you may remember, it feels like we talk about hearing aids every year in some way, shape, or form. It's a very long history and has slight nuances that seem to change every year or every other year. Trying to keep the benefit as stable as possible. Since the board previously approved a structure without cost share, we're just maintaining that and only bringing you the minimum necessary changes to resolutions on this hearing aid benefit. Again, because it has changed so much, so frequently. Like I said, I feel like we are constantly talking about hearing aids and refining this from a legislative perspective and from a plan perspective. I think this is the fourth piece of legislation on hearing aids in the last 5 or 6 years. So lots of refinement constantly in this area. So we just thought it would be good for now to keep that stable and continue providing those in the structure that the board approved without cost share before. But that's not actually a legal requirement. So just wanted to give that clarity.
Next slide. So as a reminder, adopted in June 1st, 2023, Resolution SEB 2023-05 resolved that beginning January 1st, 2024, prescribed hearing instruments in all uniform medical plan UMP plans will be covered up to $3,000 per year with hearing loss at least every 36 months without member cost share. Coverage for members enrolled in UMP Achieve 1, UMP Achieve 2, and UMP Plus is not subject to member meeting the plan deductible. Coverage for members enrolled in UMP High Deductible is subject to the member meeting the plan deductible. Next slide. So we are proposing to rescind that resolution. So effective January 1st, 2026, Resolution SEB 2023-05 as adopted on June 1st, 2023 is rescinded. Next slide. And the proposed resolution, SEB 2025-04 UMP hearing instruments, beginning January 1st, 2026, prescribed hearing instruments in all uniform medical plans, UMP plans, will be covered at 100% of the allowed amount every 36 months. Coverage for members enrolled in UMP Achieve 1 and UMP Achieve 2 is not subject to the member meeting the plan deductible. Coverage for members enrolled in UMP High Deductible is subject to the member meeting the plan deductible. So I'll stop there for comment or questions.
Sometimes we bring you like a red line version and ask to change a few words. Here we thought, again, as hearing aids have had so many resolutions and legislation in recent years, we thought just kind of striking and doing a clean slate would be easier. You'll notice that UMP Plus is not referenced in here, as that plan is also closing at the end of the year. So this also cleans up that aspect of this particular topic. And we will be looking at, and next year, bringing you various resolutions to decodify UMP Plus, so to speak. So this actually has a collateral effect of cleaning that part up as well. And the deductible piece is really driven by what is required by the IRS. That's why the high deductible health plan has to be treated differently. We'll actually talk a little bit more about this in the next presentation, but just as a quick primer reminder, kind of like what is an allowed amount. So a provider or facility sets a billed charge and they decide that they're going to charge $10,000 for an appendectomy, for example. And then the insurance carriers or plans negotiate a contracted payment amount, and that's called the allowed amount. So in this hypothetical scenario, there's an agreement that the contracted allowed amount will be $5,000. And then so that $5,000 is the total payment that is received for that particular service. And then you go into the plan and go, oh, has the deductible been met? If the deductible's been met by the member, then they pick up their cost share. Let's say that it's an 85-15 co-insurance. So the member picks up 15% of $5,000. That comes from the member, and the plan pays the rest of that $5,000 bill. But the allowed amount was the contractually agreed to payment amount that's received versus the billed charges. The other important part is when it comes to like in-network pieces, then there's no balance billing to the member for that additional $5,000 up to the bill charge by the provider. So just a quick little reminder primer of which words, what allowed amount means in this context, both for the board and anybody in the public.
And so that would be the nuance on in-network versus out-of-network.
Can you talk, Ryan, a little bit about in-network versus out-of-network?
Because out-of-network, they would be able to.
I believe the benefit still covers out of network up to the allowable amount.
Mm-hmm.
Which allowable amount? If they don't have a contract with the new network, do they use?
If they're contracted with Regents or by extension on the East Coast with, or East Side with Primera, it should still be the allowable amount that's agreed to with no cost share. That's my understanding from Regents.
Mm-hmm.
Okay, thank you.
And a lot of this is driven by the fact that in our state's essential health benefits package under the ACA, hearing aids are now part of that package, which is why there can't be dollar limits like this. That's what's really driving the most recent legislative changes to align with the now incorporation of hearing instruments in the state's essential health benefits package, starting in 2026.
All right, next slide. So next steps, we will incorporate any feedback that we receive regarding these proposals. Please submit your feedback to the website list or email address listed by June 30th, 2025. And then we'll bring recommended resolution to the board for action on July 9th, 2025 to the board meeting.
And I think the final reminder I have is just to, again, orient folks that we bring you the benefit design resolutions when it comes to the self-insured plan. But when it comes to benefit changes within the fully insured, it's really embodied within the rates that we bring you. So we will describe benefit changes that are incorporated within the fully insured, but you don't vote on the individual benefit changes there. You vote on authorizing the rates or not, and that embodies those changes. But for the self-insured plan, we have always, because the state has more control of it, the board has more control of it, brought you benefit design resolutions related to UMP specifically. So just a quick reminder as to why you see UMP resolutions, but you don't see fully insured benefit resolutions.
Any additional questions for Ryan? Omid?
Yeah, I did have one quick question. In the change, as you were describing it, Dave, I'm still trying to understand the allowable amount, because I believe it was there was amount listed in the previous version, right, up to $3,000, and this one just says it's paid up to 100% of the allowable amount. Do you have a sense of like, is this change just going to allow the UMP plans to negotiate that allowable amount, or is that based on other standards of how much a hearing aid's allowable amount coverage will be?
So when a plan puts a specific dollar limit in its coverage documents, that's considered a benefit limit. And that
Mhm.
dollar amount is expressly annual or lifetime limits are prohibited under the ACA for benefits that are considered an essential health benefit. So plans can no longer say that you are capped at a specific dollar amount that is listed in your plan documents, but you can have contracted rates for payment that cap the amount that the plan has as liability for the particular service. So the market, because of how our state legislation has happened in recent years, had been somewhat coalescing around somewhat standardizing coverage at around $3,000. So it's likely, but not guaranteed, that the contracted amount will land close to that, which is why Ryan said that the experience a member has should be similar at the end of the day. But it is true that over time, that contracted amount could go higher or lower than, say, whatever dollar amount is agreed to now. So hypothetically, let's say that $3,000 is agreed to by Regents within its network. That allowed amount could change in a few years. It could go down to $2,500 or it could go up to $3,500, but it's always that the plan has to pay 100% of whatever the contracted rate is. And so that's why we usually haven't said the word allowed amount in resolutions, but we kind of need to here because of the way that this benefit is structured. Is that a little bit helpful, Hamid? Do you have a
Yeah,
follow-up?
that is helpful. I guess I was curious if for members, as Regents now tries to negotiate this, whether this would increase the number of providers and accessibility to hearing aids, or what the changes might be in that sense. But it sounds like ideally little to no change for members.
And there is network adequacy requirements for access to this benefit as well. So I just wanted to say that based on your last couple of comments about access. So our state's network adequacy requirements apply here too.
Okay, thank you so much.
I guess I would ask where the rubber hits the road is in the rates. Are we anticipating any rate increase in the premiums associated with the hearing aid benefit changing?
The answer to that is no.
Okay.
We are not anticipating rate changes.
Okay.
It's
So-
being implemented similar to what our projections were based on how our benefit limit was structured, but it's no longer an actual benefit limit.
Makes sense.
Donna.
Follow-up question on that, the allotted amount. Where can a consumer see that amount so they know how much they can spend? Because I'm dealing with medical bills now and I'm getting things that the allotted amount is, and I have nowhere in our documents that I can look to see what that allotted amount should have been with that contracted provider.
You want to try to take that one a little bit? I can.
As we refine this benefit, we're going to be hopefully listing out allowable balance and other information. But certainly there are numerous ways to try to determine what your allowable amounts are, including certificates of coverage. We do a lot of, in open enrollment, we do benefit comparison documents. And a lot of people that have plans don't bother to look at that because they say, I've got what I've got and I'm fine. But you would be surprised what you learn because we update those every year. And so if an allowable amount changes, an out-of-pocket max changes, any of that sort of thing, we list those in those documents. A nifty little trick, it's kind of annoying, is just to get accustomed to opening your certificate of coverage and Control F keyword searching the word allowable or out of pocket max or whatever, and or dollar amount even, and you'll find it. Certainly our team and HCA generally is very helpful in helping you find that information too. So in terms of reaching out to regents, reaching through the UMP customer service line, going online to their website or our website, as it were. They do list out, if you have a regent, if you're on UMP, I'm being very UMP centric here. If you have a regent's account and you log in, it'll actually show you how much allowed you have remaining, or I mean, sorry, out of pocket max, medical deductible, and you can get your EOBs and see what you've been paying and what you will be obliged to pay. And it's also a portal there to be able to talk to regents and ask those sort of questions as well. I don't know if that's helpful.
I think another way of doing it is just talking with the provider. So you're in there, you're talking with them, you tell them what insurance you have, and the conversation sort of will happen about what hearing aids you would qualify for, and which ones you might have to sign a waiver to do.
Yeah, I think that's the difference that people like today. You think of it as, oh, I can go where I want, buy a hearing aid, and I get reimbursed up to $3,000, or the plan pays the first $3,000. In this future state, the members need to focus more on the network status. If they're in network, it's, oh, all of these hearing aids are covered by your plan. As long as you're not in the high deductible plan, you don't have to worry if your deductible's met or not, but these are covered and they're in the plan. Or these require waiver because you want to do an upgrade and you want to do something beyond what's covered by the plan. And then so it's really more about network status, because that is the proxy for what is, it does, whether if it's in network, it doesn't matter whether the allowed amount from the member perspective, as long as you're not in high deductible, is $3,000 or $3,500, because it's covered. It's either covered or not covered. And so the network status is the better proxy as the member is looking for hearing aids in this future state. That's probably hopefully more helpful for how the consumer experience would be.
And as you can see, we have some communicating to do with our members so that they understand this.
Mhm.
Yep. Other questions? Ryan, thanks so much. Appreciate it. Next up, Sarah Whitley, Herb Finance Manager in FSD. Oh, it's not FSD anymore. It's the Finances, Services, and Healthcare Purchasing Administration. That rolls right off the tongue. And Ryan will be staying for part of this presentation as well. We're going to be talking about Senate Bill 5083 that passed in this year's session. Materials behind tab number 5. Sarah, welcome.
Good morning, Chair, members of the board. My name is Sarah Whitley. Again, I'm joined by Ryan Ramsdell, who is taking the lead on many board agenda items today. I'm here to talk about Senate Bill 5083. This was agency request legislation that the agency ran and passed just a couple months ago. Next slide here. Starting with a little bit of background. Really market-wide, we've seen growth in hospital service spend and recent contract negotiation activity lead to quite a bit of member disruption and premium impacts that we've observed across both the PEB and the SEB programs. On the other hand, reimbursement for primary care services and behavioral health lag behind those increases that we see on hospital reimbursement, despite the benefits that we know primary care and behavioral health services provide to our members. So when the agency started brainstorming around agency request legislation last summer, early fall, we looked to other aspects of our markets. Washington, the Cascade Care Select program that operates on the individual market here in Washington, and then some of what Oregon has done with respect to similar pieces of legislation. And we noticed that they've all found success using what we're calling a reference-based pricing methodology or reference pricing methodology as a tool to contain costs. If you're not super familiar with what's happening in our individual market or in Oregon, the Cascade Care Select program, there are a suite of plan offerings on our individual market that use reference pricing in a similar way that we'll kind of walk through here in just a second to cap reimbursement across all services. And the success that they've seen via those plans is a slower increase in the trend on premium increases for those plan offerings, really with the focus on cost containment. Oregon ran a very similar bill. We've actually modeled our agency request legislation off of the Oregon version of the legislation back in 2019, I believe it was pre-pandemic, establishing caps on hospital reimbursement. And so we look to our peers and the success that they've seen in these methodologies to help model our legislation. I think reference pricing is not something that we have talked about much with the boards. And so on the next slide here, I'll go ahead and provide an overview of what reference pricing is before we kind of dive into the goals of the legislation and some details around the bill as passed. Really, reference pricing allows for a standardized reimbursement level for a payment of services. So we just talked a lot about allowed amounts. Allowed amounts are the contracted rate that is paid from a carrier or payer to a provider for a service. Medicare, operating in the Medicare space, also has allowed amounts. Those are not negotiated amounts. Those are established amounts based on some underlying methodology, right? Medicare doesn't go to every hospital and negotiate an allowed amount. But the Medicare fee schedule really allows us to define and establish a defined pricing level for services so that we can talk about different hospitals and different providers in a similar fashion on an apples to apples basis. Medicare reimbursement is really commonly used as a reference price because it's transparent. It's a publicly available fee schedule. It's one that is approachable for many of us who work in the market. And oftentimes we refer to the Medicare allowed or Medicare as a percent of allowed as what Medicare would have paid for that service. So on the slide here, we have an example for you. And the bill, the reference pricing bill that passed through the legislature establishes caps based on a percent of Medicare allowed. So we figured this example would help us kind of structure the remainder of the presentation. And plan allowed as a percent of Medicare allowed is truly just the ratio of the plan's contracted amount or the plan's allowed amount and the Medicare allowed amount for that service. Every service has an established allowed amount and Medicare allowed amount. And when you take the ratio of those two things, you get the plan allowed as a percent of Medicare allowed. So a simple example that we have on the screen here for service X, we can call it whatever we want. The plan allowed amount, the negotiated amount, is $100. Medicare would pay $50 for that service. So in this case, the plan would pay 200% of what Medicare would have paid for that service. So we use, again, reference pricing as a way to benchmark. It's a benchmarking methodology to help us understand and compare and contrast how different services and different providers are reimbursed across our market. So now that we have a foundation for what reference pricing is, we move into the next slide. We'll talk a little bit about the goals of the legislation. There were really three main goals here. The first being affordability, creating a sustainable cost growth for those high-cost facility-based inpatient and outpatient services. The bill establishes caps on reimbursement for those services, really with a goal of cost containment. The second is investment in primary care and behavioral health services. The bill establishes floors on reimbursement for provider types and certain service types that are defined as primary care or behavioral health services, really with the goal of improving access via an investment in those types of services. And the final goal is provider network stability. I think reimbursement caps and disincentives that are also included in the legislation for providers to move out of network should limit member disruption via fewer termination notices that we know provide quite a bit of disruption for our membership, and improvements in provider network stability as well.
Before we move on from this slide, that last point, I just want to talk a little bit. During Cade's presentations throughout the year, you might remember me in the earliest iterations of the bill talking about how there was a requirement for providers the affected providers to participate in our plan. That morphed into a different stick, if you will. So there's not a requirement that the contract has to be accepted if it's a good faith offer by the carrier. Now it's if you reject as the provider or the facility that network contract, your reimbursement as an out-of-network provider is capped at a lower amount than the cap that is set and allowed for if you are a network provider. So it's not that there is a requirement to contract, but there is a financial disincentive and a lower reimbursement cap in the bill. But that means there still could be some of these network termination notices that happen within UMP and the rest of the portfolio. You very well may have remembered me saying the current version of the legislation would essentially eliminate that termination phenomenon in our portfolio. That termination phenomenon can still happen in what passed finally, but the final version of the bill, but there is certainly a disincentive, which Sarah will go into more. So I just wanted to clear that up because it could have stuck in your minds very prominently that I was like, oh, this whole network termination thing goes away. It doesn't go away in totality anymore.
Is there an abundance of people who actually do go out of network for services? I don't know percentage wise how that works, if that's even a, a point, you know.
So the cap on out-of-network services is less around the members that receive services out of network. It's more of an incentive for providers and hospitals to stay in network because we're capping the amount that those hospitals receive from a carrier in payment. And the provider termination notices that we see are really the early warning sign that negotiations with providers aren't going well. And it's kind of like, we're going to go out of network if we can't reach an agreement on negotiations. These caps establish more structure around those negotiations such that if a provider wants to go out of network, they're going to get less from a carrier for the members who see their service or seek out their services. So it is, I think, a really powerful tool that will help our carriers reach agreement with providers, I think, quicker than what we see today. It's just another tool in their toolbox that the legislature has established via state law to help limit those provider termination notices. To Dave's point, they may not go away completely because everything's a negotiation. But the goal here is to limit the disruption via fewer termination notices.
And I wanted to mention that there's a lot of talk about reimbursement, but there are other benefits to having a contract with our third-party administrator. There are protections written into that contract and requirements in the way in which they engage our membership and so forth. Without that sort of contract, they aren't held to that same stipulation. So it's not just a matter of holding them accountable to fee schedules per se, but also the requirements in that contract for all the other stipulations. So we want to encourage it if we can.
So we've talked a little bit about what reference pricing is, the goals of the legislation. If we move into the next slide, we'll get into a little bit more around what the bill does as passed, in the version as passed by the legislature. Our affordability bill, we're referring to it as the Affordability Bill, Public Employees Affordability, applies to all of our PEB and SEB health plans. So those are all of our fully insured offerings and also the Uniform Medical Plan administered by Regents. It establishes caps or maximums and floors or minimums on carrier reimbursement effective January 1, 2027. So we've got a little bit of a runway here until we hit that implementation date. The boxes on the screen really capture the four main aspects of the legislation. The first is caps on inpatient, outpatient, acute care hospital services at 200% of Medicare, or 200% of what Medicare would have reimbursed for those services. Caps on inpatient, outpatient, pediatric specialty hospital services at a % of Medicaid ratio of cost to charges. It's a little bit different than what we've just discussed using Medicare as our reference price. For pediatric hospital services, we're using Medicaid as our reference price, different benchmark, same concept. The third is establishes floors or minimums on primary care and behavioral health professional services at 150% of Medicare. So providers must be reimbursed at or above 150% of Medicare. And then finally, as we just discussed, it establishes caps on out-of-network inpatient, outpatient facility reimbursement at 185% of Medicare. That is less than the in-network cap of 200%. And no balance billing is allowed for out-of-network services under this provision of the bill.
So typically, as a reminder, if a member does seek services that are out of network, they can be billed for the difference between the allowed amount and the billed charge. So my hypothetical example from 5 minutes ago of the $10,000 appendectomy that has an allowed amount of $5,000, the member, if they went to and had that service out of network, the provider could charge the additional, dollars from 5,001 to 10,000 to the member. That's what balance billing is. But here in this context, even out-of-network inpatient and outpatient services are prohibited from balance billing. That is, the legislation declares that. And so that protection is still there for the member.
Yet another disincentive for providers to move out of network. So digging a little deeper here on the next slide, we'll touch on the first two boxes on this last slide here, caps on inpatient, outpatient, acute care hospital services, and caps on pediatric specialty hospital services. Our carriers, all of our carriers, are required to ensure that reimbursement to these hospitals do not exceed the caps established in the legislation. HCA is charged with monitoring compliance on an annual basis, and we're kind of just kicking off the methodology build up around this work. And the goal is to engage with carriers via a reporting process on a regular cadence.
Sarah, before we move off the slide, I think there might be the somewhat of a question of why do we have Medicare generally, but sometimes Medicaid as a different benchmark? Could you provide a little bit of context on that?
Sure, yeah. I think, as I mentioned on our reference pricing overview slide, Medicare is a really common reference price when we talk about a reference pricing methodology. With respect to pediatric specialty hospital services, Medicare might not be the right benchmark. And really, especially for children's hospitals and children's services, right? A Medicare fee schedule is built and based on an over 65 age population. Children's hospitals don't serve an over 65 age population. And so the legislature took a lot of feedback during session here around this topic and ultimately landed on a Medicaid ratio cost of charges. It's same concept again, we're capping reimbursement, we're just using a different benchmark. If Medicare's a yardstick, Medicaid ratio of cost of charges is a meter. The methodology is very similar. It's just we're using, again, a different cost aspect to cap those services.
Thanks, Sarah. And I hadn't thought of the yardstick meter analogy. That's a great one. I love a good analogy.
Next slide, please. So primary care, behavioral health, and out-of-network, again, our carriers are required to ensure that reimbursement to providers for a defined set of primary care services, which will be established by HCA, and also behavioral health services, is at least 150% of what Medicare would have reimbursed for those services. The carriers are required to ensure that this pricing methodology is established in their contract with those providers. And again, the goal is to invest in this aspect of care delivery for our membership. And we've touched a lot on out-of-network, but again, out-of-network facilities are required to receive the lesser of bill charges or 185% of Medicare, lower than that 200% of Medicare cap for in-network, and members can't be balance billed. Next slide. We'll kind of close out with some of the final nuances in the bill. We talked about how the caps apply to acute care facilities, pediatric hospitals, and then some floors on professional services. But there are certain facility types or hospital types that are exempt from the requirements under this legislation. Those are critical access hospitals, sole community hospitals, which are hospitals that typically reside in rural locations, and also a couple other facilities identified in the legislation. Island Hospital and Toppenish Hospital are two of note. The ultimate results in projected cost avoidance as modeled today do result in decreases in plan expenditures, which should impact member premiums and potentially member cost sharing, where coinsurance is applied. So where allowed amounts decrease and coinsurance or a percent of the allowed amount is paid, we should see relief in member out-of-pocket spend for those types of services.
And Sarah, just to put a finer point, when you say relief, the way I describe it is downward pressure on increases. It's not that there will necessarily be cuts in premium that are attributable to this bill in the future years. It's a lower growth rate, which results in a lower trend, which is a lower increase. A bit abstract for the day to day. That's a harder talking point to walk through with people, but it's downward pressure, not necessarily net negative pressure on premiums and coinsurance. The other piece that I think is really important to reemphasize is the legislation goes into effect January 1 of 2027. So the 2026 rates have no impact or cost adjustments related to this bill. And while, the provider or the carrier community is going to be working with providers in their upcoming contracting cycles to comply with this law effective January 1, 2027, there are prior contracts that have been negotiated. Most contracts are multi-year contracts. So somebody might be in year 2 or year 3 of a multi-year contract. Many of those have rate escalators from time to time that were previously negotiated that go into effect between now and January of 2027 that providers might still experience. And the effects of this, though, don't impact rates until after 2027. So there's a lot of work, I think, being done in the provider community and some of the hospital systems preparing for what they think the effects of this will be. But just to be clear, the actual impact of this isn't felt until January of 2027.
It's a great segue into our next slide. We've included a table here pulled directly from the last version of the fiscal note for Senate Bill 5083. This modeling was done with respect to UMP only for a variety of reasons. The main being that our fiscal notes are intended to illustrate impacts to state expenditures. The state expenditure toward employee health premiums is the employer medical contribution, which is benchmarked off of UMP costs. So we don't have a summary here detailing fully insured costs, but we thought it would be illustrative to help provide details into current projected cost avoidance, what we're calling cost avoidance in UMP, across the different kind of buckets of services that we've talked about today: acute care, children's behavioral health, and primary care services. All of this is a projection. I'm putting on my finance hat now. We used a base experience of 2023, calendar year 2023 data, trended forward 4 years to the policy period of 2027 to project potential impacts of this legislation. I think we're confident in our projections. However, projections change as more information becomes available. So we are working to refine and update this projection as more data becomes available. The 2024 calendar year experience will be available at the end of this month, actually, and I plan to roll forward the projection and refine the numbers a bit. Ultimately, we are projecting decreases to non-Medicare premiums across the board, so that's UMP and fully insured carrier premiums, in the range of approximately 1% to 3%. So to Dave's point earlier, we're not completely flipping the bucket upside down. We're just slowing the flow of water, pushing that trend. I'm really on an analogy roll today. I'm killing it. And hoping to decrease the slope of that trend line.
Before we move off of this slide, a question that I like to highlight is, you might go, why are the numbers so different for PEP and SEB? Just a reminder that in the PEP portfolio, about 80% of the population is enrolled in a UMP plan. In the SEB portfolio, it's about 43% of the population is enrolled in a UMP plan. So obviously, with essentially double the enrollment, roughly, that's why you see a lot of the price or projection differences between the two portfolios. And also, Sarah was saying, starts with a base of 23, trended forward to 27, but then the state looks at a 4-year outlook, which is why you see that scary or exciting number of 2030 for the first time in your board materials. Because the state budget has to kind of balance to a 4-year outlook. And so all of the fiscal notes project out, yes, to fiscal year 2030. So we're already there, folks.
So we'll close out here with next steps on the next slide here. Ryan and I and a group of other colleagues here at HCA are actively engaged in the rulemaking process. The bill does provide HCA the authority to engage in rulemaking and codify new Washington Administrative Code, or WAC. So that's a very large project that we're undertaking on an accelerated schedule. The goal is to have final rule posted and publicly available by the end of this year. But next steps are engagement with stakeholders around the rulemaking process, and also engagement with our carriers around the methodology and approach that we'll use to measure compliance under this legislation. It's very important that carriers understand how we measure compliance so that they can engage with their provider community in a way that ensures they meet the requirements of the bill. Again, caps go into place January 1, 2027. So we've got a little bit of a runway here. And then finally, there were 2 legislative reports, the requirement that HCA draft 2 legislative reports in the bill, really analyzing the initial impacts of this legislation on network access for members, enrollee premiums, cost sharing, and also state expenditures. There are 2 reports due, one at the end of 2030 and the next at the end of 2034. Who knows what we'll all be doing then, but yeah, much longer runway for those. But we'll be actively analyzing the impacts and providing details via those legislative reports. Yeah, it may not be me, but maybe it will. I don't know. I find this work very interesting. So
But Sarah, what's happening in 2040? Get on that.
It's a projection, Dave. It's a projection.
All righty. Questions from the board? We've got some runway on this one.
Mhm.
So I'm sure we'll be hearing about this over time. Thank you, Sarah. Thank you, Ryan.
Thank you.
All right, next up, we have Brett Mello, our CIO in Enterprise Technology Services Division, and Jean Bowie, our ERB Deputy Director. They're going to be talking about the agency's work regarding benefits 24/7 and the materials behind tab number 6. Brett and Jean, welcome.
Good morning, Chair McDermott and members of the board. Glad to be here. We'll start with our first slide. All right, so our stabilization effort that we've been working on for a number of months now has been completed. Since the fall of 24, we've been doing a lot of work to address a lot of open issues and really targeting those things that impact the user experience. So just as a way of context as to where we ended up. So of the high priority tickets, which is part of our goal, we had wanted to move it from, I didn't bring my history on this, but we had quite a large number of those tickets. And quick update on that one. Oh, we are at 32, so we've achieved that goal. Our sync record backlog, basically those are the files that are there as they're moving into pay one are having some issues of some sort or another. That is reduced down to 521 error files. Those files that have some kind of an error in them, 397. And pay one themselves with their high priority tickets, actually it's down to, as of this morning, 48. So great progress by the team to address a lot of those fires, as it were, that we've been needing to address since the last open enrollment. There's a lot more work coming up, a lot more things that we want to do to optimize benefits 24/7. We'll be talking about that a little bit today, but more in future meetings as to what some of that work is going to look like as we look to advance and mature our solution. As far as our staffing plan, we are actually going to be moving into the interviewing phase for our new manager for this group. Again, this is a manager that's going to be helping to coordinate the efforts among the benefits 24/7, the pay one team, our testing group, and our business analysts, and really getting them aligned more and more deeply than maybe what we've done to date. So that should take that group to even a higher level. We've got 4 other additional positions that we are in the process of finalizing position descriptions on. So we know what kind of folks we want to hire there. In fact, I think we've moved one of those through, and that's actually going through the process right now because there is a contract person that we'd like to be able to hang on to who's been doing testing work, and he's been amazing, and he's really interested in staying with us. So we're trying to expedite that, but those are in process right now.
And those, for the board, are all positions that were funded as part of the most recent operating budget that goes into effect July 1st. So the rare IT investment, staffing investments from this past budget debate.
All right, next slide. So there's a lot that we have to do now in preparation for our open enrollment. And so our teams are beginning that transition to really focus on those tasks to get prepared for a successful open enrollment this fall. Making updates and I'm still learning some of this since I'm new, but as I understand it, we've got a variety of things in let me look at my cheat sheet here. In text and language that we want to update this coming round. There's testing that we have to do. Obviously, we need to be planning on sunsetting UMP Plus. So a whole variety of things getting ready for successful open enrollment this October. We are still going to work on bugs. And things are just going to, there will always, in any kind of software, there'll be new things that crop up, and we will continue to focus on those things and make sure those are prioritized accordingly. So we're staying on top of those. Focus group of benefits administrators, we've been talking with those folks to get ideas on how do we make the open enrollment wizard even better, specifically for dependents and spousal attestation. So that is in process right now to really identify where those opportunities are to make that open enrollment process even more smoothly. And then, of course, actually going through and doing the testing of any changes that we make for open enrollment. So that's the kind of the period of focus between now and September, really, before we begin to do what we call a moratorium, or basically stopping any additional development during open enrollment period. So we're just supporting open enrollment.
Yeah, it might seem interesting or thinking it's June, open enrollment's in October. That's only 131 days away. And when you have to have a code freeze and a moratorium in there, that eats up some of that time. It's strange. There was just a reference like a week or two ago that we're closer to the next open enrollment than we are further from the last. And I was like, no, that can't be true. Yes, it is. We are only 131 days away from OE.
So like kids counting down to Christmas, our staff is actually counting down to open enrollment. And there's a certain level of excitement because, we think that that this open enrollment will really kind of represent and reflect all the work that's been done. It'll be really seen and felt during this coming in open enrollment. So there's a certain level of excitement about what this experience will be this time around. So the team is very engaged and looking forward to what's coming.
130 days, 14 hours, and 8 minutes.
But who's counting?
Because somebody will sign in at 12:01 a.m. on the first day of open enrollment. They do. No, that is not Dave. I might be 10 p.m. on the last day. I won't be 11:59, but I might be 10 p.m.
All right, next slide. So one of the things that we're starting some work on now, even though the launch will be post open enrollment, is what we call an application programming interface. And basically, if you just think about it, it is a way for one system to communicate electronically with another system, to automate the flow of information, in this particular case, enrollment and demographic information to flow from UW or Washington State smoothly from their system right into ours. So it really dramatically reduces the amount of manual labor to make that happen. That will be a significant benefit to our partners, and certainly make it easier for us to get the data that we need. And so we're getting things ramped up. We're starting that work now to get ready for all of that. So working on, creating that simple and repeatable solution. Our plan is to do that initial development this summer with the intent of launching in the spring of 2026. And we're working through those details with WSU and UW right now. So that's kind of the next big process improvement for us that's coming down the line. And then there'll be other organizations, as I understand it, additional partners that we'll be reaching out to. These are just the two that are the most obvious, the larger stakeholders that we want to take care of first. So.
And then stepping back to kind of even the 50,000-foot level. So we have benefits 24/7. I don't even know what the current game console is. PS5, is that the current game console? Interfacing with the Atari Pay One accounting system from the 70s. One of the things that, we talk about syncing issues, it probably makes sense that a PS5 and an Atari have trouble sometime interacting. But one of the things is all of our carrier files come out of our Pay One Atari system. And so the carrier files are where we have been seeing over the last year that disconnect between the member going in benefits 24/7, I'm enrolled in plan Y, but the carrier doesn't see that because the data for that particular member hasn't synced from our PS5 to our Atari so that the Atari can push out its, regions file, so to speak. We want to be able to move that carrier file to come out of benefits 24/7 so that the syncing of our PS5 and Atari aren't impacting the enrollment experience of what the member thinks they're in and the plan thinks they're in. But one of the big things that has to be done before we can do that IT development is the University of Washington in particular, their data and PEB is going directly into Pay One. For school districts, all of their data is in benefits 24/7. We launched the SEB program with SEB My Account, which was the predecessor to benefits 24/7. There's always been some sort of data integration. All of their enrollment data starts and has always started in a we'll say PS4, which became PS5 gaming console. But for PEB, we were moving, it was all interfacing originally with our Atari. We moved everybody over to the PS5, except for the University of Washington. We were having some challenges, but we can't have all of our carrier files come out of our benefits 24/7 system until we have all of the data for both programs starting in benefits 24/7. So that's why the API work is so important and starting with the University of Washington. We're doing it at the same time with WSU. All of those are PEB employers, but that's necessary for us to be able to then move the architecture of our IT systems in a direction that moves us away from our Atari console. Thank you, Sarah, for inspiring analogies today.
I was going to liken it to Pong, but that'll probably date myself, how all that is. But that's the kind of the challenges, how aged our Pay One platform is. So, all right.
All right. Next slide, please. Good morning, Chair McDermott and members of the board. Jean Bowie, ERB Deputy Director. So I've got an update on our the weekly communications that we have been doing with benefits administrators to keep them as up to date as possible on the stabilization efforts. So as Brett mentioned, the team is moving towards the open enrollment preparation and that sort of a thing. So we're going to pivot our communications and go to an at least monthly cadence with those. The team is still going to be working bugs and that kind of a thing. So we'll be communicating those, and if there's a need for more frequent communication, if issues arise, then we will do that. But the need for the weekly communication is changing with the work of the team. And so we are the communications, the historic communications are being maintained on the BA website. So folks can still access those for reference, but it's just kind of how the work is migrating.
You almost said hysterical.
I almost did.
The hysterical communications. Do we have questions or comments from the board? Appreciate all the great work that's been done on that. I know it's been a slog, and having an old system and a new system and having them try and communicate, and the old system's the system of record and the new system, very complicated. I appreciate it. All right, next up we have public comment. So what we're going to do is capture everybody out there. First of all, anybody in the room from the public want to make a comment? Seeing none. Out in Zoom land, if you want to make a comment, you raise your Zoom hand. We'll call on you. We'll give you the ability to turn off or turn on your camera and your audio, and give your comments. Yes? Okay, who is it? Hey, Fred Yancey, he's back. How you doing, sir? Let's go ahead and give him the ability to turn on his camera and his audio.
I think I'm doing okay. Can you hear me okay?
We can hear you.
Well, first of all, thank you for all your work you're doing. I certainly appreciate it. And adjust my computer here. I really just have a series of questions, and I can follow up, or you can follow up. The presenters can follow up my concerns. The first concern was Omed, and excuse me for using your first name, pointed it out regarding the hearing instruments. The change to go from a $3,000 cap per ear to allowable amount opens up the door for a substantial reduction in benefit potential. Although if I understood Dave correctly, and I think I did, that there must be some law or regulation that says you can't set a dollar amount. I hope I misunderstood that, but I think that's why they moved to the wording allowable amount. But as a potential user for hearing aids, I'm concerned about opening that door. The the other piece is when you were talking about the benefit design amount. Oh, I'm sorry, about 5083. I'm a little confused because at least in terms of one of the slides regarding, let me see if I got it, regarding services must be reimbursed at or above 100% of Medicare. I thought this was a program that put caps in place. That implies that there isn't a cap, at least for the primary care and behavioral health benefit. So it's just a confusion on that part. And let me see if there's um, and uh, and the third point I would make is my opinion, um, and it's often jaded. So, but I have always been impressed by the quality and expertise that the IT changes have been made through the Healthcare Authority. I have monitored on behalf of clients other IT projects and other agencies, and I'll tell you, your agency is to be commended for the quality of the product they produce. In the IT field, I'm always impressed. With that in mind, thank you for your time. Have a great afternoon, and thanks for the shorter meeting, by the way.
Hey, thank you for your kind comments. And I think Dave is going to take a swing at a couple of your questions.
Yeah. Fred, I especially wanted to address, you were like, did I misunderstand or mishear? After January of 2026, the combination of federal law, the fact that our state has the insurance commissioner's office has added hearing aids to the CMS approved essential health benefits package means that effectively there is no ability to have a defined benefit limit in the way that our plan currently does. So we say the plan covers $3,000. That is a classic, quote, defined benefit annual or periodic increment, because this time it's every 36 months cap. That is, once a benefit is elevated to essential health benefit status under the ACA, can't have those types of benefit limits. So we no longer, as of January 1, 2026, can have a guaranteed reimbursement type. You can spend $3,000, and
Gotcha.
if you want to spend more, you can spend more, but the plan only pays $3,000. That type of express dollar limit is no longer able to be the hallmark of the benefit design. And so we can't say $3,000. I was trying to provide as best reassurance as I can on what contract negotiations are going out, that the fact that our state has had a $3,000 limit, defined benefit limit in place for now almost 2 years, the market has started to coalesce around that number. And so it's very likely that the allowed amount will continue to be aligned very similarly with that. But you and Omid are correct that there is that risk that over time an allowed amount isn't a fixed number and it can change from contract period to contract period. That's where this shift into an essential health benefit world without a defined benefit dollar amount has us all needing to focus on what is in network or out of network, because whatever is in network will have 100% coverage, regardless of whether the allowed amount is $5,000 or $2,000. But the hearing aid is covered at the allowed amount per ear every 3 years for those hearing instruments. So hopefully that's a little bit helpful. Happy to have some more follow-up questions with you after the meeting on some more points about that. And
No, that's
then
clear.
we'll take your other question under advisement about 5083, unless Sarah wants to come up. If you already have that answer, because we're trying to thread together, Sarah, the fact that there's a floor for behavioral health and primary care, and whether and if there's a cap while there's also a floor.
Yeah, Fred. So there's a distinction made in the legislation with respect to caps placed on inpatient, outpatient, facility-based services. So there are maximums in place for those types of services. There is a floor in place or a minimum threshold of reimbursement for primary care and behavioral health professional services. So I do want to make that clear that the bill does focus on cost containment at the facility level. We've seen those rate increases outpace what professional providers receive for primary care and behavioral health services. When we looked at the data, the majority of behavioral health providers and a large portion of our primary care providers are reimbursed below that 150% of Medicare cap today. So that's the goal and the intent of establishing a floor, is to bring those providers up to the minimum or above, invest in those types of care delivery, thereby increasing access for members to primary care services and behavioral health services. I think if we invest in that, the goal is to invest in that subsect of the market by establishing caps on facilities and bringing up reimbursement to primary care and behavioral health. Does that help?
It does, and I appreciate the clarification.
Okay.
So,
Thank you, Sarah. All right, our next meeting. Oh, I'm sorry. Were there more? Okay. Yeah, good point. Nobody else has signed up for public comment. Our next meeting is going to be July 9th, 2025, starting at 9 with the same format. For attendance, you can either be here in person or on Zoom. Dave, any final comments?
Yes, as a preview of coming attractions, I anticipate that we will have one more executive session. We probably will start the meeting with an executive session and then move into the public comment, just to give you final insights about the culminating rates development process as we then prepare in the public meeting to roll out the proposed 2026 premiums and the premium resolutions. We'll also bring back for action the resolution Ryan brought forward on hearing instruments today. And then it's already time to talk about the 2026 board meeting schedule. And so we'll also have a preview of that. I will say that seems like it's usually a fairly boring topic, but there is a lot of more considerations that we were trying to factor into the 2026 schedule and want to share with you and kind of gauge your reactions to it. So, that might be a little bit more exciting than 2 minutes next time.
Ooh, Dave's leaving us wanting for more.
We're trying to avoid this week, the week that has Juneteenth, as we're learning that school districts, as they're building their calendars, are trying to find ways to time the end of the school year with the variability of weather days to end before having a strange transition where there's a holiday that then kids have to come back for one more day. So we thought with all of that variability, we're going to try to avoid the week of Juneteenth for board meetings in the future. That's one of two factors. So just, you might have been thinking about this week, as this is the end of school for many districts. And we wanted to try to give all of our board members who work in school districts not having the choice of do they attend one of the last days of school or not. So we're trying to be more thoughtful about that for all of you too.
Awesome. Any questions or comments from the board before we close? All right, Dave, thank you to you and your staff for all the great work, and board members for attending today, and the public who was with us, and we will adjourn. Take care.